So tell me a little about yourself.
I'm called Dr. Eric Lugada. I'm a medical doctor and an epidemiologist.
Where'd you get your medical degree?
I studied at Makerere University in Uganda, in Kampala.
Okay.
And then I did my PhD in epidemiology at the Center for International Health at the University of Bergen in Norway.
You know, like, if you have a degree, you could have got a very well-paying job just being a private practice. Why did you decide to help people?
Ever since I finished med school in 1995, I've been working with HIV-infected communities, and I had this desire to work with communities and to respond to the HIV/AIDS epidemic. Then we didn't have any medication for treatment, so all we did, we were supporting them, providing treatment for opportunistic infection, and it captured my imagination. It captured my passion to work with communities, and that's the reason why I did epidemiology and still choose to come and work right here in Africa, addressing issues of communities, large communities that are affected by epidemics.
If my friends see this video and they want to learn about AIDS, the AIDS epidemic in Africa, what would you tell them?
I'll tell them that the epidemic in Africa is different from the epidemic in Europe or other countries, Latin America. It's a totally different epidemic because in Africa, the epidemic is within the community, it's within families. Most of people in Africa, particularly in countries which have had high prevalences like Southern Africa, Eastern Africa, the epidemic is right next door. Your brother, your sister, your cousin has been infected with the disease. And this is because the mode of transmission in Africa is through heterosexual transmission. It's normal sex between man and woman within us. So it's not in groups. In most countries, it's in special groups like injecting drug users, sex workers. In Africa, it's within the community. So the disease is in families. And most families have seen it.
And that's the thing. A lot of people don't know. Like, they think it's sex workers. They're used to knowing it in a particular region. Sex workers, drug users, heavy drug users. But it seems to be like everyday families here.
Yeah. In Africa, it's everyday families because it's transmitted normally through sexual intercourse, man and woman, anywhere. So most families have been affected.
Wow.
Friends, in-laws, relatives, brothers and sisters.
Have you seen, this might be a tough question, but have you seen a lot of death?
Yes. I've seen a lot of deaths, especially in the beginning, in the early 90s, late 90s, 1990s, when we didn't have access to antiretrovirals. All we could do as doctors were to manage patients symptomatically, treat the pains that they have. But there reaches a time, if you're not taking antiretrovirals, when your immune system is so low that eventually you will die. And most times I've had to be at the bedside of patients. They are dying and they ask you a very hard question. Doctors normally don't tell the patients that you have a few days to live. But these patients say, I want to know the truth. Tell me, doctor, if they have an infection like cryptococcal meningitis, which is a fungal infection of the brain, they will surely die in a few days. And they ask you, am I going to die soon or am I going to live? And you're faced with a painful news which you have to pass on to a patient who is dying. And they know they will die. But once you tell them, they're happy. They say, at least I know, and I'll die in happiness, knowing that there was somebody there who was caring and looking after me.
How do you cope when you see all this death? I asked the same person to someone who had seen death by malaria so many times in Bangladesh. And I guess now that you've seen a lot of death by AIDS, how do you cope?
It's difficult, and every case is unique. You'll find that we are persons to begin with. We're individuals before you become a doctor. And one of the philosophy of being a doctor is that try to empathize with the patient, but don't get so much taken up in sympathy. It's a thin line when you're a human being, and it's difficult. But it also goes beyond that. There are patients who become really close to you as individuals, and when they die, we definitely get shock. We get a shock. But at the end of the day, you know, you have thousands of other patients to look after. And if you let the death of one patient bring you down, you may not be able to look after the other thousands of people. So we go through a momentary loss, feeling of disparity, the feeling of being in despair, but eventually you recover and you have to move on. Know that I have 1,000 more, I have 2,000 more to look after. One has gone, time has come for them to go, but I must move on. So that keeps us going. But every time you lose somebody, yes, you feel something.